So we have an excellent panel assembled to continue our discussion of addiction, the opioid epidemic, and how we can attempt to leverage the science of vaccine development, or some other appropriate term we can all agree on, to help people suffering with addiction. In addition to Drs. Sullivan and Rieder, we are joined by Dr. Amy Caruso Brown. Dr. Brown is a pediatric hematologist oncologist at Upstate and associate professor of bioethics and humanities and pediatrics. Dr. Tim Endy is an infectious disease physician scientist and the chair of microbiology and immunology at Upstate. Tim is also the co-founder of Road to Recovery of Central New York, which is a not-for-profit organization supporting people's entry into long-term recovery programs. Finally, we're joined by Congressman John Catko, representing New York's 24th District. Congressman Catko has decades of experience as a U.S. attorney, working in narcotics enforcement, and as a federal organized crime prosecutor confronting the intersection of drugs and gang violence. As a member of Congress, he has introduced legislation addressing both synthetic drugs as well as opioids. And Dr. and Tom, thank you very much for sticking around and going to the airport a little bit later for us. Okay, so how I'm going to do this, I have some specific questions for each of you, but everyone should feel free to answer the question. And then Tina's going to help with questions coming in from Facebook. So the first question I'd like to ask is for Dr. Sullivan. So you are often involved in the care of people with addiction at a kind of personal crossroads when they're making decisions to enter recovery or to continue using. What do you see as the greatest barriers to moving more people towards recovery in the current system of care, and what do you see as the greatest opportunities to improve the system?
Well, I think, you know, unfortunately how, you know, we talk about social determinants of health. We talked about them a little bit harder, and we talk about, you know, what's so difficult when people are at the crossroads to get them into treatment or recovery. And it's difficult, right? Because oftentimes we're dealing with people with maybe low education, you know, no access to communication, no access to other types of health care, so on and so forth. So it's very difficult, and we demonstrated today, it's very difficult. Addiction is not just medicine. It's so multi-compartmental in terms of how we have to treat the people. It involves so many different things. So to get people into treatment, we require people to come to groups and all these different things. It's difficult for people to do. So sometimes how it's actually constructed is its own barrier. And then, you know, the next question is, you know, is there a role for what we've been talking about today? And I think we clearly said that there absolutely is, you know. I think that if we can show, or if the researchers can show that this is a potential something that can be used to decrease death and mortality, because I said that's the basic denominator that we're all here trying to, you know, save. If this is something that can be used safely to help reduce death, used in the right people, you know, used as an adjunct, I think that we've absolutely is something that we can use. And despite all the efforts, despite the MAT, despite the naloxone and Narcan, we're still losing people every day. People who went to the buprenorphine and methadone clinic yesterday are dying today still from an overdose. So anything that we can do to still continue to decrease death and give people another day to continue on in their recovery, whatever that is, that looks like to them, is something I'm willing to at least look at and try.
Thanks. I'm wondering, Tim, if you, how many people have been sent to Austin so far? I think we're on 18?
Number 19 this week.
Number 19 this week. So maybe you can sort of describe the perspectives that you have received from the folks that you've sent down to Austin who have successfully entered recovery and have sustained recovery.
Yeah, I'd be glad to do that. And maybe I can also explain a little bit about our own personal story, because I changed dramatically from the very beginning. As a clinician, you know, I would see people who had consequences of IV drug use on the wards with infective carditis, and you know, I was compassionate, but really didn't understand. One day I asked someone, "Why don't you just stop? I mean, honestly, just stop it." And they looked at me like I was a little bit of a foreign animal, and I didn't understand. And my story changed when my own son became a heroin addict. You know, I walked that walk with him. He went from a 180-pound athlete to a 140-pound addict who was near death. He overdosed 3 times, resuscitated each time across ER and sent right back out on the streets. He failed 2 rehab programs that each of them lasted 14 days. And I saw him get into the Justice Center because he relapsed on drug court. So he was jailed for 30 days. And so we were really at a crossroads, and I began to understand this walk of addiction that he had to make. We finally got him into a program in Arizona that detoxed, and then a long-term recovery program in Austin, which was 6 to 9 months. And he finally reached recovery. And what we realized, and he's now 3 years sober. He's happy, productive. He's helping other people in the recovery. And the lessons I learned by this walk was several. One is that the cost to us for his health care in recovery was $150,000, which was not covered by health insurance. And my wife and I thought, well, how can anyone afford to get into a long-term recovery program? Because insurance would not cover for it, number one. Number two, that addiction is achievable. Recovery from addiction is absolutely achievable. That sobriety and a healthy lifestyle can be achieved with the right program. And it takes much longer than 14 to 28 days here. So that was the second important thing that we learned. And so we started this charity where we're helping fund people into long-term recovery programs that last up from 6 to 9 months in Austin. And we funded in the last year and a half 19 people to go down there. So as a clinician, my son's experience changed me fundamentally, dramatically reducing any kind of stigma associated with it. It is now, I appreciate it as a very complicated, complex disease that requires multiple tools to be able to address.
Thank you. Yeah, I mean, for my own 2 cents, and Dr. Brown and I are thinking of ways to address this issue, is the bias on the part of the medical professionals. Until you have met a number of people who are dealing with addiction and you ask how they ended up in that spot, you immediately think it was they make bad decisions, they make bad choices. And that may be the case in some instances, but more often than not, it was a pathway that started with some kind of traumatic injury or some kind of illness or something that resulted in providers prescribing opioids and then cutting them off. Or it was, we were talking at break, they had grown up in a culture of use, not a culture of abstinence. And so it's just, you can't completely understand. And I think one of the things that we want to work on is by starting with the first-year medical student, or you can broaden that to any kind of medical provider, and really trying to indoctrinate them into having an open mind about things and to recognizing bias and to trying to be a little bit more objective and look at it as a disease and as an illness, and not, as we've talked a number of times this morning, as bad choices that people make. So does anyone else want to comment on that first question?
I just want to say that, the thing that I learned from my son, that this is a disease. Despite being 3 years sober, he goes through the big book 4 or 5 times. He does his meditation, and he tells me that addiction's a lifelong disease. I have to work at it every day, and it doesn't go away. And I think we have to change the conversation, as was said this morning, that this is a chronic, debilitating disease. And Ross and I can tell you that we lost someone really important last week, who was very, very special to us, who was 6 years sober and then relapsed and OD'd and died. And it just sends a message home that there is just no cure. There just needs to be multiple tools available to help people stay sober in recovery.
Thanks. So my next question is for Dr. Brown. So you have experience treating children with very serious medical problems, of which pain syndromes are associated with those problems. So I'm wondering, how do practitioners approach prescription of opioids in the pediatric population? And do you share the same concerns about fueling addiction that your adult medicine colleagues might have?
Yeah, so one of the reasons I wanted to be on this panel is because I think pediatrics is the smaller part of medicine and medical expenditures, and the smaller part of these conversations. So I wanted to represent that. So I treat children with cancers and blood disorders many of whom will need opioids or will not have a better option. And there's other serious diseases, many of which are more curable than they've been before. So more of those children are growing up to be adults who may continue to need opioids. And I think one of the ways in which pediatrics has failed so far is that we've been a little bit cavalier about it. I was taught not all that long ago, I graduated from medical school about 10 years ago, that if you needed the opioids, you couldn't give too much. That you couldn't make someone addicted if they need it, which of course is biologically completely untrue. We know everyone will become dependent if they're on it long enough, but that influenced how we prescribed in pediatrics for a long time. I think some of that stigma too, children are luckily less likely to be stigmatized, but it also makes us in pediatrics less likely to appreciate the risks of exposing them to opioids. And I think we're now just starting to understand that yes, early exposure does change the brain. It does make you more likely to become addicted to drugs later on in life, and we need to think about that when we're prescribing. At the same time, we know untreated pain changes the brain and changes the brain in negative ways. So we're always trying to balance those two, and I think I want to make sure in any conversation that we're thinking about that. What does the future look like for children who do need these drugs now, who may need them later? How do we come up with options that will help to protect them later? And it probably doesn't look like a vaccine, but I'd like to make sure that we're thinking about those things. And then the other piece of the pediatric puzzle that I wanted to add is that our children, the children we're taking care of, are also often also the children of adults who have had these challenges and faced addiction. And when we're talking about harm reduction, we're also thinking about reducing the harm to their children. And that may mean living with a parent who's on maintenance therapy, and that might be a great outcome for that child, that they now have a stable home, that they're going to see fewer of the adverse effects that we see in children who have grown up in homes with parents who are suffering from addiction and not getting access to treatment.
Thank you. So, Dr. Rieder, so in the bioethics literature, is the pediatric question, has it been raised? Has it been discussed?
So I'm actually starting to work on a similar project right now, which I think I was telling Dr. Brown about last time that I was up here. But we have a shared colleague. His name is Yoram Unguru, who's a pediatric hem-onc doc down where I'm at in Baltimore. And one of the things that he and I are jointly really concerned about is he gave this term, what he calls cancer exceptionalism. And we're concerned about it writ large, but he's especially concerned with children for some of the reasons that Amy was talking about. And so the idea is our prescribing practices have come up in an era of where cancer pain and cancer care was largely palliative care. Cancer was a death sentence, and so it was very perverse to withhold medications. But now that so many of these cancers are survivable and children are these incredible vulnerable population with potentially a very long life ahead of them, hopefully, you do have to be really careful about what sort of planning you're doing for patients, because obviously they need genuine pain care, but the idea that we don't have to plan for them longitudinally is really problematic. Yeah.
Right. Thank you. So my next question is for Congressman Katko. You were a federal prosecutor for many years battling the drug trade, and the opioid crisis has been one of your top legislative issues. Where do you see the greatest opportunities for the federal government to affect change in the opioid crisis?
Well, thank you, and thank you for having me here today. And we all have stories about someone we know we've lost due to overdose, and all I got to do is pick up the paper every day and go through the obituaries, and you can tell the ones that are gone. I think I know you're talking about from last week as well. Congress has a lot to do with this, a lot, and it's many different ways when you think about it. And I just want to digress for a moment. I'm sure you talked about these stats, but it's important to remind people. By the time this panel is over in this hour, 5 more people will have died of an overdose in this country. And 5 more people have also committed suicide in this country in the next hour. And of those 5 people that committed suicide, there's 29 attempts for every suicide. So, and I would argue that suicide and mental health goes hand in glove with some of the self-medication that's going on that's leading to this. But if you really step back and you look at it, Congress's role is really a 3-headed attack in my mind. It's prevention, it's treatment, and it's law enforcement. And let's start with prevention. Prevention and treatment together, really. Giving the federal dollars to the local, to the front lines to try and help with prevention and treatment, getting down into the schools. We did that with the Comprehensive Addiction Recovery Act, which appropriated over $4 billion. And then subsequent legislation put together a whole package of, I think, 30 different bills to deal with all the prevention and treatment that we possibly could think of to try and get to the front lines and then to get people treatment who want to get treatment. But it's a drop in the bucket for what's really needed, because we all know that treatment for heroin addiction, and in particular opioids, is a long-term inpatient, and there's nowhere near enough dollars for that anywhere. We're trying to get insurance companies to cover more of it as well. But then think about this from the law enforcement standpoint. Last year alone, they seized enough synthetic fentanyl at the southern border, alone at the southern border, to kill every American twice. That's what we seized, and that's not what got through. And then that doesn't even count the synthetic fentanyl that's coming across from China via the U.S. mail. So there's been a lot of legislation trying to deal with border security, a lot of legislation trying to crack down on the synthetic fentanyls being shipped into this country from China, but we have a long way to go. But the synthetic fentanyl is what's really one of the fatal components most of the time in the heroin overdoses, because for some reason they mix it with it, and that's what we see. But so there is a lot we can do. There's a lot more we need to do, but really a lot of times it boils down to dollars and cents, and $4 billion sounds like a lot, but for this epidemic, it's nowhere near enough. One thing I've been trying to do is trying to talk more about the interaction between the mental health component and the addiction component, because we are treating the heroin epidemic as it rightly should be called, an epidemic. No one talks about the mental health crisis in this country in general, and the suicide crisis in particular. And those two things, I venture to guess a lot of heroin overdoses have mental health components tied to it. I think both numbers are underrepresented in what's really going on in this country. So prevention, treatment, and law enforcement all go together, and we have a long way to go.
Do you think most of your colleagues in Congress look at this as a criminal issue or as a health issue?
I don't think they look at it as a criminal issue anymore. They understand it's a mixture of both. But I think they also understand that this isn't the heroin addicts we remember growing up. And the stereotypical heroin addict when I was a kid was someone in the inner city in a dark alley shooting up. Well, this could be a high school athlete, and oftentimes is, who gets prescribed a drug that doctors didn't even know was as addictive as it is. And then they get hooked on it, and they go to heroin as a substitute. That's why I give you one example too, and this is nothing against the doctors here, because I know that doctors here would never do this. My former chief's wife had a baby by cesarean section, and everything went fine. She's very healthy, no problems. She's leaving the hospital in Washington, D.C., and they tried to give her a 30-day supply of OxyContin. And she says, I don't want it. I'm not in that much pain. Tylenol's fine with me. I'm okay. They basically forced her to take it out of the hospital, the 30-day prescription of OxyContin, which she promptly dropped in a garbage can. So we all have a responsibility not to overprescribe, but there's also a pressure on the other side for doctors that they get rated poorly if they don't take care of the pain properly. So there's a Hobson's choice a doctor has to make, and I think that's part of what we need to work with the medical community on to try and help them. And one of the bills I introduced was a bill to say first-time users can get a 7-day prescription limit. They already have that in New York State. They should have it all over the country, and then go from there for pain management with doctors. But there's a lot that needs to be done, and it's prevention, treatment, it's law enforcement. It's also trying to engage with the community and trying to engage with the doctors. What are the best practices and what can we learn? And that's one of the reasons why I'm glad I'm here, because I'm absorbing a lot from this. But I know a lot of people who died of heroin overdoses, and it's just unbelievable to me, and it crosses every socioeconomic background in this country. And it's not endemic to one area or another. It's across the spectrum, and we need to understand that how bad the problem is.
Thank you. So back to Tim, Dr. Endy. Gary Matthews had mentioned a couple times that we're working together on a heroin vaccine, and there were a number of speakers that talked about regulatory complexities and ethical complexities, and I know you have some views on that. So would you mind kind of sharing your view on who should and should not be able to participate in these trials and why you feel that way?
Thanks, Stephen. Because I'm going to summarize a long discussion we've had that's been ongoing about this, and it was really great to hear the lecture this morning, especially the FDA's perspective on not using normal, healthy volunteers. And Congressman, what we were talking about was using the vaccine like the heroin vaccine or fentanyl on the safety studies and who is the appropriate population. So normally what we do is healthy volunteers who have no health problems, but the FDA has come back and said we can't do that. We have to use it in the population that's suffering from addiction. So that's part of the controversy that's ongoing. So I guess for the audience, it's important to understand the different clinical trials that we do to get a drug or vaccine licensed. And they go from phase 1 to phase 3 efficacy studies and a longer phase 4 for long-term safety. And the phase 3 efficacy study measures the effect of the vaccine or a drug in a population that has the disease. So by definition, the phase 3 study will ultimately have to be done in the population who has addiction, so that we can measure our endpoint of efficacy, whether it's reducing overdose deaths and harm reduction or relapse rates or some other endpoint for efficacy. But the problem comes in those first-in-human studies, the phase 1. Because traditionally we take a population, because we don't know if there's any benefit to this vaccine or not. We don't know if it's going to work. We don't know what its effects is. And the phase 1 studies is purely for safety. We want to make sure someone's arm doesn't fall off, that their hair doesn't fall out, that their skin doesn't peel off, and those things. It's just purely safety. So we want people who understand that this is a safety study, who are perfectly healthy, and they go through an extensive screening before they volunteer to do that. And they have to understand to volunteer phase 1 that there's absolutely no benefit involved in this, because we don't know if it works or not. So they do it for either altruistic purposes, or they do it because they get paid $3,500 to participate. So that's the kind of the premise for the phase 1. What bothers me ethically is by doing a safety study in a patient who is in recovery, and it may be 6 months out from his last use or her last use, there is an implicit definition of benefit behind the name heroin vaccine. And that to me crosses the boundary from a population that has no interest in it at all to some population that may potentially do it because there's an implied benefit. So that bothers me ethically, what I think needs to be a discussion about. Plus, we don't know the long-term effects of that psychologically. So, for example, someone who takes a vaccine and they relapse, do they now go more higher doses? Are they at higher risk for actually ODing because they thought they had the vaccine that's protecting them? So there's other downstream effects that also bother me about that as well.
So I'm going to ask Travis to comment, and then I'm going to go down to Tom, because Tom, you have the most experience with doing human clinical trials. So I don't know, Travis, you want to have some comments?
Yeah, no, I shared the concern that there are really issues on both sides here, and so it's just going to be really fraught, which I suppose is why we're talking about it. But yeah, so if the FDA were to allow healthy subjects, that would have been one concern, because that's not the target population, and so it's not clear what kind of useful information we're getting at the outset. They're not going to allow that anyway, and so we have to use it in the target population. I have, in addition to the kind of unintended consequences concerns that you've articulated, Gary was talking about the challenge feature of it, that you'll deliver a dose of morphine to do the measure. There are going to be a lot of people in recovery who believe that real pure abstinence is the only way to kind of maintain their sobriety, their recovery. And so the recruitment strategy is just going to have to be incredibly delicate. Like, who can you bring into this that exposing them to morphine when they have the vaccine on board, not knowing what the reaction is going to be, might not potentially disrupt their recovery process, right?
Well, so for clarity, that was only going to be in that first group, so people that have no history.
Oh, there's not going to be a challenge.
Correct.
Yeah,
there was not going to be a challenge.
When he said that, I was like, whoa.
Yeah, no, I saw you awake.
Yeah. So I do think that the recruitment process on both sides is going to be fraught. But that's true every time we're working with vulnerable populations. Right. The only other piece that's worth mentioning on the research ethics side was the conversation that was had about pregnant women. And there's a lot of work that's been done in the years since the cocaine vaccine was being done. Right. And so there's work that folks at my department, like Ruth Faden, Maggie Little at Georgetown's Kennedy Institute of Ethics, have been doing to show that we really might not have any justification for withholding the trial in the population of pregnant women, especially because we might think that this is a population where it's especially useful. So there was the comment made about protecting the fetus. And so getting FDA approval based on a population that excludes pregnant women and then hoping that it was going to do something for pregnant women is a recipe for moral disaster. So that's another thing that we're going to have to reckon with.
So I remember in college studying what they call, if I remember correctly, they called these therapeutic orphans, so children and women of childbearing age who would not be involved in clinical trials, and therefore data would not be generated that necessarily applied to them. And I know most recently when, because we had a lot to do with the Zika outbreak response, there was a ton of literature coming out in the bioethics community about, enough is enough of excluding pregnant women from trials where the intended audience or target population was going to be that group. So, Tom, you've dealt with the FDA many times on this topic.
Yes, and also doctors, lawyers, and Indian chiefs through the National Academy of Sciences.
Right,
and,
right.
We did write a book about it, and the pregnant women were certainly, or women capable of becoming pregnant, was one of the more debatable issues. But the other thing that came up in that discussion, which was the first studies that we did with the cocaine vaccine in cocaine had to be done in cocaine abusers. The FDA was insisting on that back then. But they were also quite concerned about the harm that might occur if we gave this vaccine and it, in fact, drove people to want to use more cocaine. It stimulated their craving, or they tried to override it. I mean, just what was going to happen. And so they insisted that we do this study, which took over 3 months to do, just with the vaccinations and measuring the antibody levels, in a controlled residential setting. Now, back then, the controlled residential setting that we found was merely about $400 a day. Finding that controlled residential setting now that's going to permit you to also vaccinate people and follow them and lock them up may not be as inexpensive as that. And the question is, how much do we need to spend on these studies to ensure safety of the individual participants, which would probably not be such an issue if you had normal subjects. If you ask them not to use opiates because this is supposed to block it, you usually can get their cooperation. To say that to someone who's in fact an opiate abuser and then say, and this vaccination may in fact also block some of the effects, but in the consent form you have to indicate it is a competitive antagonist. We don't know if we're giving enough of a dose to in fact block any dose of opiates you might take, and in fact you might be able to override it by taking more opiates. Now, in an outpatient setting, that might be like an invitation to disaster, right? Because you're taking something, first off, some of the people are going to get a placebo. And the question is, how are they going to test out the opiate? Now, if they test out the opiate by smoking the opiate, the advantage to that is you get an effect within about 15 seconds. So you will know pretty quickly, okay, I've smoked enough. And then you can just throw away the rest of the opiate, right? Well, maybe yes, maybe no, it's already lit up. If you are injecting it, on the other hand, once you push the needle in, you just push. And if you think that you're not getting enough, you'll be sure to push in well, let's try double the amount. You never know. They may have not been lying about the vaccine. Maybe it does do something. The idea of individual safety versus the group safety, or what's ethical to do, I think is not trivial. And some of the arguments that we made with the FDA was that you appear to be stigmatizing and discounting the lives of substance abusers compared to the lives of someone who's not a substance abuser. And I don't know how that fits into an ethical framework, because I'm not an ethicist. I'm just the kind of guy who argues with authority in general. But this is a real issue, and I hope that there'll in fact be some action by Congress on this and one other issue, which is right now harm reduction is a dirty word in the federal vocabulary. That is, you're just beginning to see it in terms of opiates with needle sharing programs and exchange programs for that, for injecting drugs in a setting. So some of this is a view that the only good treatment is one that totally leads to abstinence. And that, I think, is a viewpoint that's basically destructive to these. So I would think of it in a variety of those questions that come up, some of which are amenable to changes in federal legislation, or at least a hearing or two from the FDA to see how they're thinking about how to make life better.
I know someone in the federal government.
Yeah, I want to make sure I understand what exactly the ask is, because I want to go back. So what exactly are we asking for to do? The FDA can change their practices. They have shown a propensity to lately. So what exactly are you looking to have changed within Congress?
Two things. One would be in developing treatments for substance abuse, that if we develop treatments that reduce the amount of substance abuse but don't necessarily lead to total abstinence, and the examples of this are...
Right now they're not allowed to do that?
Right now you're not allowed to do that with anything except alcohol. With alcohol, a couple of years ago, they made the approval of a medication called acamprosate based on that it decreased heavy drinking. Didn't lead to abstinence, but it decreased heavy drinking. That was a landmark decision. It's not been generalized to the other drugs of abuse at any point, and this seems particularly important with opiates because, you know, lots of people get opiates. Why should you say that you have to get abstinence from opiates as your outcome when that's totally unrealistic? So that would be the first. The second point was, how do you conduct some of these newer studies where you're looking at a new medication to treat substance abuse? With virtually every other medication that we've talked about, other than the vaccines, they do in fact start with normal individuals and see how does it go. What makes vaccines so different, and what is the misunderstanding about them? And we could explore. These are not, as I think several people have said, these are really therapeutic agents. They're not vaccines in the usual way we think about vaccines, and that may be a distinction that needs to be important. So there are two issues that are in there.
Yeah.
And just quick follow-up.
No,
I'm
please.
sorry. And anybody can answer this. Have you spoken with FDA, and what has their response been to these, if any?
I've spoken to the FDA, cajoled the FDA, had the FDA at a congressional hearing a long time ago now, just about these very issues. And the FDA's response was relatively fixed and unwavering. And some of it came from even with ONDCP, which of course is now that's the Office of National Drug Control, policy, which has become a non-entity now. They were actually an ally in trying to get some of this furthered, but some of those federal offices have in fact been neutralized.
But I think now is a good time to reapproach with that conversation, because I think people even when you look at infectious diseases, people are starting to look at vaccines as not binary things. So if you look at influenza vaccine, most people think, does it work, does it not work? Did it prevent me from getting influenza? Well, it might not have prevented you from getting infected with influenza, but it might keep you out of the intensive care unit, and it might prevent you from having a heart attack, within the next year. So I think the idea of harm reduction versus this all or none should be on the table, and I think it is on the table, and we should go back to them. But Tim, to your point, there's no risk of someone getting dengue or yellow fever or any of these tropical diseases that we make vaccines and do the initial studies in places where they don't exist. So this idea that you must do it in the target population, because of the reasons you already mentioned, I don't know. I think there's room for discussion about that. So one of the things I wanted to ask Congressman Katko. So if you were to take two maps, and one map was opioid overdose, ER visits, hospital admissions, and death, and then you overlaid pharmaceutical distribution of pills, I think that they looked very similar. So West Virginia and Ohio and Pennsylvania. And I'm wondering, and I guess there have been some heavy penalties that are being proposed for some of the companies. I wonder if you could share with us what is the conversation in Congress about this phenomenon and what to do about it, or how to prevent it in the future.
Well, yeah, I lived it a bit in my previous job as a federal organized crime prosecutor, and For 20 years, I went after cartel-level drug traffickers, all the way down to, you know, the main people in the communities I was living in El Paso and Puerto Rico and back here. And so all manners of drugs come around, but nothing that came close to the lethality of the heroin overdoses now. Nothing even remotely close to that. So then when you trace it back, I remember seeing as a prosecutor, Purdue Pharma, for example, just to talk about one, paid the largest fine in history to FDA for not disclosing the addictive qualities, right? So I look at that and I say, well, obviously we have to go after those people. And I've kind of, quite frankly, I've encouraged the government and municipal lawsuits against them for what they've done to our communities and what they caused by not disclosing that, because that clearly, to me, was a catalyst for a lot that's happened. And West Virginia was ground zero for that. They called it the hillbilly heroin, right, because it was the overprescription and the underreporting as to the addictive qualities was the match that started this fire, in my mind. So you have to look at that and look at what we can do to going forward with those companies. And one of the bills I introduced, like I said, was to limit prescriptions to 7 days to try and help with that. And I think the litigation is going to solve a lot of the problem with respect to the pharmaceutical companies and the exposure they have, and rightfully so. But it's not, by no means is going to solve the problem. But that is one of the biggest components of it that I see. And some of the other things I'm learning about today with FDA, we've got to start thinking outside the box and listening more to the medical community about things that we can do and we should try and do. My feeling is, and I think the feeling of most of the people in Congress, is all hands on deck. Mm-hmm. Like I said, the law enforcement side, the treatment side, prevention side, and now the clinical side is something I haven't really thought much about, but that's something we need to address. And you know, you got to make tough calls, but when the house is burning, you can't sit there and fret about it. You got to just try and take action. And I think any idea is a good idea if they think it's going to help the problem. And I think that's the current attitude of most people in Congress. The Comprehensive Addiction Recovery Act passed with the vast majority of support on both sides of the aisle. And that's a good example of bipartisanship in a time of hyper-partisanship. And this is something that I think if the issues are brought to us, I think you're going to see bipartisan action for it.
Thank you. Ross, so back to you. Can you describe a little bit the Bridge Clinic and how that works?
Great, thank you.
Yeah.
So about 3-4 years ago now, identifying the problem that we're all talking about, the Northeast emergency departments have been have had a huge increase of patients with opioid-related problems, stemming from overdose to withdrawal to infection, right down the line. And it is true. We used to give people a piece of paper and discharge them on their way. And that was just what was taught, and just like when you were taught in medical school and residency, right. And, there really was no formal education on this. And, when you would see people continually come back in or die, I realized that we needed to do something else. So we started seeing patients in the emergency department and giving buprenorphine to patients in withdrawal or after an overdose, or someone maybe who just needed it. And then I would see them back every Wednesday morning on my own until my boss found out. And he said, I can't be seeing people like in the ER, is like my own clinic. So he was right. So we were able to find a spot in the hospital, and we started seeing and having them come back to an actual clinic. And we would start them on buprenorphine in the emergency department, and then we would get them in hopefully within 3 to 5 days. And there we would provide them the medication further. But what really I found out was over time was that was the smallest portion. That was a small portion of it. That took care of a medical need or the withdrawal or cravings. But that people have all kinds of other things they suffer from, right, from homelessness and joblessness and other medical conditions. And I'm finding that those are just as important to take care of at that point as that is, because if you don't take care of those, then they're not going to continue on and being, heroin or fentanyl. Their chance of overdosing are still pretty high, mm-hmm, if we return them back to where they came from. So we try to solve as many social determinants of health as possible, and we use peers, which are people who usually have some lived experience, but also help patients in their road to recovery. And it's been an unbelievable journey. We've probably seen over 600 people. 70 to 75% of them we have gotten into treatment after the clinic.
That's great.
Yeah.
So they recently expanded the educational opportunities for providers to be able to prescribe Suboxone. And so there's lots of folks that are not addiction specialists or that are not toxicologists that are now able to prescribe. Have you seen any, are you in touch with the expanded Suboxone prescribing community, and how do you think that's been working?
Yeah, absolutely. I think in some ways, I think one of the things that's helped amazingly is that we've allowed advanced practitioners, so nurse practitioners and physician's assistants, that some of them are over here. Without them, I think the epidemic would still be continuing to even worsen. I feel that physicians primarily are still reluctant to do so. I feel that if they're not specifically trained or waivered, or they're trained in addiction, even if they get their waiver, which means they're able to prescribe buprenorphine, they're not using it.
Right.
And that's because, we don't know the chicken before the egg, or we don't really know exactly the best way through all education. And where it does start is what you mentioned. It starts the day one in medical school.
Right.
And I always talk about how I learn about diseases that have been eradicated. Which is important to know, don't get me wrong. I learn about very esoteric things, yet the addiction I didn't learn about until my family was actually affected and until I was in the emergency department seeing people come back all the time. And that's a shame. And we need to start at the ground level because we're still kind of trying to play catch up right now. And I think that's the only way, is to continue to put it out there, educate from day one. So hopefully we can get to a point where it's become commonplace.
I just want to add to that. This is a perfect example of us in Congress listening to you folks, because a lot of people came and talked to us about two things. One is expanding the universe of people who can prescribe the medicine, but also uncapping so some doctors can only prescribe, it was like 100 patients at a time?
With 30, then 100.
Right.
And then
So I think we uncapped that as well. So those types of things we didn't know until we heard from you all. So the more you identify pinpoint fixes like that, we can do that. And I know for sure we fixed this thing, and I'm glad to hear it's working.
Yeah. Tim, do you have any comments? Or?
No, I agree totally. I was
Okay.
nodding my head and, yep.
It's not often that someone nods their head and agrees with somebody in Congress, so that's good.
So I would like to go to the audience. I'm hoping there are some questions from the audience for our panel. Great, there's one right there. Medical student.
Hi.
Yep.
Oh, okay. So I think we've heard a lot today about how treating addiction and treating all of this issue is multifactorial, and I think we're all agreeing that the vaccine could be one component of the treatment. So I'm just curious. I'm just a student here, and I'm just curious specifically at Upstate, what is our goal with this upcoming clinical trial for the vaccine? Who are we targeting as a population? Because Syracuse does definitely have a very interesting population, especially the city of Syracuse. And how are we going to ensure that the population is treated fairly and ethically, specifically in our case here?
Tim, have at it.
Well, I guess speaking just from our group, looking at this, I see the vaccine as being just one very small tool in a toolbox of other things that could be used. As Ross mentioned this morning, there are several critical time points in someone's recovery where they're at risk for relapse, and that usually comes like at 4, 6, a year, and sometimes 2 years after they've stopped using. And that's because addiction is a long-term process. And what happens is they become sober, and they go back using a dose that they were using at their very peak, and then they overdose and die. If we can get something that covers them long-term, that has a durable level of protection, that they don't have to keep coming back every 3 months to get an injection or whatever, that can be used in conjunction with other medical bridge therapy, then that to me is a very important tool in that toolbox. And I think that's what we envision this vaccine to be of use in the population. Now, what we will plan on doing is recruiting people who are in recovery, and we have a very strict ethical IRB process that has to go through in terms of informed consent and education and making sure they understand the risks and lack of benefits or whatever there is behind the vaccine, so that we can do it within the standards of ethical norms.
Yeah, so both, the FDA's focus is on safety. So before you can do any trial in a human population, they're going to look at how it's manufactured, what's the data in animals look like, what were the quality systems that were in place, the purity, all these sorts of things. And then, and what is your plan to ensure the safety of the people who are going to participate? And then it's the independent ethical review committees or the institutional review boards who are completely separate, objective, disinterested in the project, who will then look at some of the more nuanced bioethical issues. So the idea of are they a vulnerable population or not? Is the compensation that's being proposed, is it coercive? And I think this is a very interesting discussion for me, or concepts for me, because if you say, well, I would give $25 to someone without addiction who comes in, but I'm only going to give $15 to someone who does have addiction to come in and do, commit the same time, that's as equally problematic to me as, from a, the coercion discussion on the one side, yet the clear, I guess for lack of a better word, discrimination on the other. So yeah, these external objective committees would come in and weigh in on the plan and ask us to make choices. But again, what we're talking about is and Tom told you his timeline, 20 years of developing cocaine vaccines. We are at step 1 from a clinical standpoint. Which again is to just determine that there are no major safety issues with that. But we're going to have about 14 months to have a conversation with the FDA and the IRBs about that. So, other questions? Oh, great.
Hi, I'm with the College of Nursing here at Upstate. We have a new grant that we just got funded about a month ago that looks at opioid and substance use disorders, and it's targeted into our psychiatric NP students. So we have a multidisciplinary group that will look at it from an advisory board level to integrate some things into our curriculum. One of the questions I have for you, for all of you, is how this interacts with primary care. I know that Dr. Sullivan's group, actually one of his NPs came through our program. She's going to be a dual certified NP in primary as well as psychiatry. So she'll carry both of those pieces with her, which is really, really important. But I'd like to hear all of your take on not just the prevention, treatment, recovery, and as you added, Congressman, the law enforcement model as well. So there's kind of all of those bookends. But how does that connect into all of the day-to-day primary care that happens to keep folks out of coming into the Bridge Clinic? And I know this grant gives people tools to recognize these substance use disorders in the primary care and integrative care settings, but it's much bigger, as you mentioned, in pediatrics specifically. They're not looking at that just yet of how are we going to keep the kids safe. We can prevent all day long, but what are we doing with primary care to treat some of these things?
Yeah, and my discussions with folks at Upstate in the past is, my understanding is there's everything, you get taught everything in medical school. Mental health isn't always intertwined with everything as well as all the other maladies, if you will, and especially in the pediatric realm. And so we've been trying to provide funding and trying to provide congressional focus to integrate that at that level. And the other thing we've been trying to do is trying to get better insurance coverages for those. So like one-stop shopping for insurance and covering all that stuff. So you don't, a lot of times, but if they're not covered, they may not be treated as well. Right. So that's just a fact. But the biggest thing I've found through examining all this is the lack of mental health training for the average pediatrician. And that's a real concern.
Yeah. So Amy, can we have you? Yeah.
Yeah, so I think that's exactly right. There's primary care providers, pediatricians, family medicine, even the internal medicine residents. It's been extraordinary to me when I talk to them how much mental health care dominates their practices. And if you think about residents providing that coverage, you're talking about people who come through for 3 years, who are excellent but in training, who are being asked to do a huge amount of this outpatient care. And the more we can do to provide those resources, the better, particularly for children and particularly for the children I see who have chronic medical problems and really need that medical home. They need the access to the psychiatric care. They need the awareness on the part of their primary care pediatricians or family practitioners, whoever they're seeing, about drugs like opioids, about the long-term risks, One thing we are slowly doing better in pediatrics is this idea of transition to adult care, that we don't just say, you turned 18, goodbye, and send these kids who are medically complex, who often are on chronic opioids or other pain medications, and just turn them over to the adults, but that we do that process gradually. And I think we have to embed conversations about opioids and opioid use into that transition, but that also means we need enough primary care providers and enough mental health providers that on the day they turn 18, they're not just left floating in the wind. And for a lot of our kids who are on Medicaid, they have much better access to care as children than they do as adults. So that is one of the huge problems I see, that you can be a child with sickle cell disease and get pretty good access to care, pretty reliable access to care, to some extent even mental health care, not as great as it should be, but to some extent. But then once you turn 18 and you flip over to the adult world of Medicaid, assuming you get to stay on Medicaid, it's a totally different ballgame, and we have much more difficulty getting good providers for those kids.
Something you mentioned, just to give you some examples, like to illustrate things, and what you said I want to back up. CPEP is here in town. They do people in crisis for mental health, for example, right? A lot of times there's drug components with that as well. I met a kid there was 18 years old, had been to CPEP 20 times. And that means he was in crisis 20 times and thinking about taking his life 20 times, oftentimes in conjunction with drug abuse. And I asked him, I go, what did you do when you got out? He goes, well, nothing. What do you mean nothing? He said, nothing. Any follow-up? No. Any mental health treatment that you got after you got out of those crisis moments? Because they can only keep you for 72 hours at CPAP. He said no. And that is a gigantic gap on both the mental health side as well as the substance abuse side. They may stabilize you if you have an episode, you get to the hospital, but there's not enough follow-up, and it's not a criticism of doctors, it's criticism of us as a country for not providing the resources to have that follow-up to try and stop this from happening. So you're absolutely right as far as that goes.
So Travis, and then Tom, I know you got to get a plane, so we'll go to you after Travis for your final words.
So I love this question, and I have lots of thoughts on primary care physicians especially, but in a lot of the work that I've done on ethics and policy issues related to opioid prescribing in particular, one of the most important things that I've discovered and spoken with clinicians about is that our healthcare system is just deeply, deeply fractured. And so we get dropped handoffs, we get miscommunications, we have falling through not just cracks, but deep, deep chasms. And so, you know, I saw this from the inside as a patient before I ever started working on this. And I got prescribed opioids by 12 different clinicians, and not a single one of them would help me manage the prescription over the long term. None of them were looking forward to prepare for what was going to have to come. And nobody had an exit strategy, and nobody knew how to taper. So think about this, right? That one of the things that we might hope primary care physicians ultimately do is they provide something like longitudinal care in a deeply fractured system where the orthopedic surgeon is never going to follow you out after that initial prescription. And, you know, not to pick on orthopedists, but, you know, the plastic surgeon is never going to follow you. And so if you can develop a sense of nurse practitioners and PAs and primary care physicians and people who are actually going to become a kind of glue and take responsibility for patients over the long term, and then learn really crucial skills like weaning off opioids. Because there's this sense that when you've been on opioids long enough to go into withdrawal, say, which we had a conversation about earlier, that, you know, you've developed an addiction. Well, no. This is, you've developed a dependence, and if it goes untreated and it's not cared for, then this might become a feedback loop that helps to feed an addiction where you escape withdrawal by going back on the medication. It reinforces the reward center loop, right? So if you have somebody at that point to know you, to take care of you, to help you through that weaning process with just fairly teachable set of skills, you can disrupt this kind of deeply fractured non-system system. So I think primary care physicians sit at a great place, and that's not even going yet to getting X-waivered and taking on buprenorphine prescriber and kind of seeing the whole length of time. So that might be more than you wanted, but there you go.
Thank you. Tom.
Well, thank you. I'm, of course, sitting next to a primary care prescriber who appears to do all the right things, which is he recruits other people besides physicians into this, since I agree with you, nurse practitioners, PAs, et cetera, seem to follow the rules a whole lot better and are in some ways more responsible than physicians are, who always want to think it out for themselves and they've got a better solution. And then on top of that, you really are at the cutting edge in terms of taking people from the emergency rooms, putting them on buprenorphine as opposed to sending them out the door when they've, you've just precipitated withdrawal to some extent in them with the naloxone, so they're not feeling terrific. But in fact, that's the perfect time to give buprenorphine, because you want to be in a little withdrawal so that you feel better when you get the buprenorphine, and then having them back anywhere from 1 to 5 days later. The 5 days often is when it happens on Friday night, and you're trying to figure out when you can see him next. And I certainly admire the fact that you got in trouble with the head of your emergency room because you were trying to operate a primary care practice inside the emergency room. That is exactly what needs to happen, though, because what's happening now is emergency rooms are inundated at $1,500 to $2,000 a day with people who need primary care. Drug dependence is not the least of those problems. In fact, it's one of the more stronger contributors. So I don't have much else to say other than complimentary things about the person I'm sitting next to, who in fact sounds like he's doing all the right things, and I'm sure that that's making his family terribly happy, since he's never home that much and you do all that kind of stuff. And it sounds like in pediatrics that the thought that people who do have to prescribe a fair amount of opiates sometimes, which is the hem-onc people who are treating kids that are in terrible pain sometimes, thinking about how that transition is going to happen when they hit 18, particularly for something like sickle cell disease, which I think is, in the bad old days when I was just starting, they would often get sent to methadone maintenance. And it was just a mess once they got there, because of, they get acute pain and the methadone's not going to fix that. So God bless you. And I'm going to give this to you so you can say more about your good
Thank
deeds.
you.
And I'm going to run.
Okay, Tom,
Travel
thank you very
safely.
much. We got a question in the back, Chris?
Yeah, so, I thought all the panelists, you guys have done a great job today and with your talks. So Dr. Reiter, you said a lot of things today I completely agreed with. Didn't agree with all of them, but because I do like this as a therapeutic vaccine, just not preventive. But given what you had pointed out, the complexity of the disease and the fact that the news headlines kind of capture this in a specific way, I do think that this is going to be a tool, as Tim has said and others have said, in treatment, much like malaria, right? So malaria has never been something where you could just use bed nets or indoor residual spraying or point-of-care diagnostics. You need the therapeutics and the vaccines as well. How would you, with all of this stuff going on, how would you approach the PR component of this when it does come out, or if it ever does come out? How would you approach this so that people don't think of this as a one shoe fits all kind of a situation?
Such a good question. I work with journalists enough to know that it doesn't matter how carefully you craft your words; they're going to choose the headlines. And
Congressman, is that?
So my biggest worry about vaccine is really about those headlines that I showed on the slide, right? And so if we I'm really not going to get stuck on the terminology. And so if we could get a careful, nuanced message that people would understand, I'm happy to call it a vaccine. But the message that I want everybody to be on board with is that this is one treatment among many, and it does not get us away from the need for maintenance treatment. As a matter of fact, what we talked about is that maybe one of the best uses of it is alongside maintenance treatment, because you can't do that with our previous bulwark against relapse, which is naltrexone. So if you think about it, this is one tool among many. It's a great new tool because it has this feature that you can combine, right? Mm-hmm. And then somehow, which of course this never would work as an actual PR campaign, but championing the tool as coming out and not allowing anybody to think that we've therefore made this giant step that negates the need to do more, right? Because that's the thing that I'm most worried about, right? I was talking with a couple of folks over lunch who saw the grand rounds I gave a couple weeks ago in public health, and I used this infographic that Josh Katz did for the New York Times, which is brilliant. So if you want to find it, it's something like how a police chief and so would spend $100 billion to fight the opioid crisis. So that's enough. Josh Katz, New York Times, police chiefs, $100 billion, right? And the great thing about this infographic is it shows supply, demand, treatment, harm reduction. How would 30 or so of the leading public thinkers about this topic allocate these resources? What's super important is that where this would go, where this vaccine would go, would be just a tiny little square on a pretty massive heat map, right? Which is not to say it's unimportant, because every one of those little squares matters, right? But a really big square is harm reduction, is in needle exchange programs and airdropping Narcan across the country, and hopefully opening safe injection sites. I don't know how the congressman's going to feel about me saying this, but then also making sure that we have MAT, treatment on demand, as a menu, so methadone and buprenorphine for people who need it, and then if the vaccine's on board, also available for people who need it. Making sure that it's available on demand everywhere, which we are 90% shortfall from, right? 1 in 10 people with opioid use disorder actually get specialty treatment. So, well, and it's actually worse than that, because probably about a third of those have access to MAT. So we're just so far that when we roll it out, it can't sound the clarion that we solved the opioid crisis, and that's my big worry. So yes, let's just let the scientists take a bow for having done something really cool and impressive, and hopefully it's a tool among many others that helps us, but we've made this one very small step forward in this massive battle, right? How do you do that with headlines? I don't know.
Right. Well, Travis, you notice we didn't call this substance abuse vaccines, right?
Yeah, that's right.
We called it countermeasures.
I like it.
And that was before I even met you. Other questions? We have a lot of questions up here, Tina.
Hi, Congressman Catco. I'm Dr. Bonnie Grossman. I've been in your office in the past year with Physicians for a National Health Program. We had a couple meetings with you, and I would like to just make a connection between what we talked about at those meetings and this seminar today, because this is one of the biggest reasons why we have a fractured healthcare system that Travis was talking about. And because our fee-for-service system has put every doctor and every practitioner in their little box, they've learned to protect their area, protect their income. And that's where we get unequal treatment across our country. And we talked to you about the New York Health Act because New York is trying to lead with this concept, but it really needs to be a federally solved problem. And this is a perfect example of what it costs society in the long run, because we can't fix it up front, so that all of these people, it's an illness, it's a disease, it's not treated that way in this country, and until we get a program where all of these people don't have to worry about getting their care. If Tim Endy didn't have a lot of money, his son wouldn't have gotten the care he got. And he's a perfect example of what thousands of people in this country cannot do for their family and their kids. So I just want to make that connection, because I think what we talked about was very preliminary, but I think this is just a real vivid example of why we need to make that change in healthcare.
Yeah. I understand and respect your point, and my only response would be, that sounds great, but there's simply not enough resources available right now, and we as Congress have to do better with making those resources available for addiction and treatment recovery, for sure. No matter what the healthcare model is, we just need to do more with that. Period.
Please.
Okay, so thank you all. This is really great. And like Dr. Endy, my perspective has changed a whole lot, mostly because of education. So I guess my question is this: going back to the fire that's burning and having to do things immediately to help save lives, how do we change public perception? Because I think there's a huge gap, even among healthcare providers, in what we know, what we've learned, and then the public at large. So, whenever there's an article in the paper, I don't like to use the Syracuse.com blog to gauge all public opinion, but it does give you an idea that if it's like 80% have a very cynical view of addiction and do not support harm reduction strategies, particularly more advanced, or don't even have a real understanding of addiction as a disease, how do we sort of mobilize public perception the way we have with other things that help drive, let's say, the federal government to do, because if you look up on the federal government website, CDC and all that, there's tons of information out there. But if you ask the average person anything having to do with the current situation in the country and addiction in general, they know very little, or it's just what their stereotypes and their stigma, inform them. So how do we get from all the new information, everything that's happening, to the public to help them mobilize and be willing to support financially, trying to really aggressively address the crisis? Does that make sense?
Well, I'll pass it on after I can make an initial stab at it, because I wanted to follow up on Congressman Katko's point, where our perception of addicts have changed since when I was growing up, and the older generation as well. We had a, concept of, Needle Park and, the whole thing. And, for me, I'm old enough now that when I was in training, the HIV epidemic started.
Yes.
And there's a lot of similarities between the stigmas associated with HIV and what we're dealing with now. And, the conversation with HIV didn't really change until it got into the heterosexual population, when mothers and wives and children were starting to become HIV infected. Then the conversation started to change, from, men who have sex with men. And that did a lot to reduce the stigma associated with that. So, I think today what we need to do is to have people realize that the addict today is our children. It's my son's friends at FM, who OD'd. It's the boy and girl down the street that's now homeless. And I think one step is for us in our charity. I don't know if you watched Channel 3 News, but we had one of our alumni was interviewed up here who is healthy, but he had OD'd 6 times. But people who see his story and realize how happy and healthy they are and contributing to society, I think it changes their perception.
Yes.
What Teresa and Ross did the other day in terms of reducing the stigma amongst healthcare providers by bringing in a panel to talk about their addiction, and they listened to the story of this beautiful 28-year-old who is a beautiful girl who tells that story of being homeless and an addict and ODing and dying in the university hospital before being revived. That changes perception. I think the public needs to hear more stories like that.
Right.
I just want to add to that. If you want to see how that's making progress, go to any high school that has a drug abuse or heroin summit, and you will hear chapter and verse examples of what he just described. And I'll just give you one more. And the reason I give this is because these examples stick with you, and they make you realize it's not someone in an alley shooting up.
Right.
This woman was an athlete in high school, and she got hurt at one point and was taking painkillers and got into heroin for a while. She kicked the habit when she got pregnant, and she didn't even take anything to help her. She just kicked the habit, and at 5 months sobriety, her baby was 5 months in the womb. Her old drug dealer called her and said, "Got some great stuff. It's not going to hurt you. It's really safe, really safe." She took one time, and her and the baby died.
Yeah.
And that was at a high school, West Genesee High School. They were telling me that story.
Yeah.
And go to any one of those. And I think that the message is out there that it's anybody now.
Yes.
Athletes are probably the number one most susceptible nowadays, it seems like, because they get hurt, they get on painkillers, and then they go from there. So I think the message is definitely changing, and I think there's an appetite. I think that's what Comprehensive Addiction Recovery Act was born out of.
Right.
Seeing it wasn't just a segment of the population, it was the truly bipartisan menace, if you will. And so I think it's out there more so than you realize. And now I think people are accepting it. It's a disease that crosses the spectrum, and then we got to do something about it and continue to fight for it.
Right.
Travis.
Thank you.
Yeah.
I think this conversation almost always needs this disclaimer, and I expect that everyone up here agrees with it, but I think we have to say it, which is epidemics climb social ladders. It's just historically has been true. And so the way that we responded to the HIV epidemic when it left just the men who have sex with men population, and now we've started to respond to the opioid crisis because it started killing white people in the suburbs. we have to acknowledge that that's a radical, terrible failing, right? So like there's been this conversation going on. Yeah, like it's more than just saying like, yes, we know you can't just respond to it because white people are dying, is that you can't then tailor your responses to address the oxycodone problem with the high school athletes, right? The heroin epidemic that has devastated communities of color for 40 years is equally as bad, and it's to our eternal discredit that we didn't see it, right? And so part of the reason to fight for really widespread response to the opioid crisis is that it's not just the high school athletes, and it's not just the suburbanites, and it's not just the people that a lot of people in power know, right?
Right.
It's everybody. All their lives are equal, and if you started with heroin, got addicted to heroin, and almost died from heroin, that doesn't make your choice less worth saving you from than if you started with oxycodone, switched to heroin, and overdosed from that. So.
And another contributing, I mean, with the HIV epidemic, I remember our own folks here treating patients and helping change attitudes across our own community. But I also remember prominent people coming out and saying, you know, this is a problem, and explaining why, you think of, the Princess Dies or the celebrities, and sometimes it's even just having, not that, that's the end all, but just having more exposure, more people standing up and saying, here's a problem, listen to these experts, listen to people, to try to help people, somebody maybe they respect, or look up to.
Yeah, if there's a silver lining to a crisis reaching truly epidemic proportions,
yes,
it's that everybody's touched.
It's everybody's touched.
And this summer alone, I've lost 3 people in my circle. 3 people in a summer. Amazing. Right? And I work at Johns Hopkins. These are children and close friends of professors, and right, everybody knows somebody. And so if there's a silver lining, it's that if you can't respond now, like, I don't know what to tell you, right? Because everybody's been touched.
Right, exactly. Thank you.
Other questions? There we go.
So the focus of this talk has been a lot on tertiary care and treatment, but I wanted to take the opportunity with Congressman Katko up there to talk about the supply side of the opiate crisis. I work in pain management at the hospital, and I do some addiction management at a substance abuse clinic here. And I've been using iStop for many years now to look and see who's prescribing out in the community, what kinds of drugs and at what quantities. And to me, it seems really easy to identify what I like to call like rogue prescribers, people who are out there really prescribing excessive amounts of opiates, or doses, combinations of benzodiazepines and opiates. And there was a story in the news last week actually, about a doc in Virginia who prescribed like $500,000 doses of opiates before finally getting busted. And that was during a 2-year period. It was just 2015 to 2017. And it kind of blew my mind that that's like within the last 5 years, which is when we've really all had our finger on the pulse of this is an epidemic. How is there actually still prescribers out there getting away with that level of prescribing before they get noticed? It seems to me like, where is the DEA's role in identifying these people? Because if I, at the local level, can just pull up, a couple dozen iStops a day and easily identify it, why aren't there bells and whistles or sirens going off at the state and local or state and federal level when that type of thing is going on?
You're absolutely right. And I don't know if there is, but there should be something along those lines, kind of like if there's an anomaly and someone's prescribing much more than the others, it may be a pain clinic for all the right reasons, but it may be a bad doctor. And the last case I did, which opened my eyes to this more than anything, was at when the onset of the epidemic was just setting in. It was in 2014, 2013. There was a doctor in Fulton who moved to Las Vegas, and there was no doctor in Fulton anymore, but he still had a clinic, and the people still came in. He was hiring people from like Video King to come in, make them go take a urine test, and if they pass the urine test, pass it by showing that there's opioids in their system, then they would get another prescription that they would just fill out on the table. He had a table full, card tables full of prescriptions and just piles that people, they weren't even nurses. They would send them, FedEx with him, he would sign them all, send them back. And they would go out and get them. And one of them, more than one OD'd on it. So they were clearly addicts, and everyone knew to go there. And he hadn't even seen any of these patients, and they were getting 2 and 3 and 4 years worth of prescriptions at a time. So we busted him, obviously, and the doctor went to jail, of course. But so a system like you're talking about, if it's not in place, it should be in place. And if you're telling me it's not, it's something we can easily fix. To say just spot checking the doctors if they have a high rated prescription is a no-brainer to me. I thought they'd be doing that anyways. If they're not, they should be. So I'll check with DEA. But that case to me opened my mind up, opened my eyes up big time to how bad the problem is with a rogue doctor and how much damage a rogue doctor can really do. And then I doubt that is anything other than a huge anomaly. Most doctors are very careful. My wife's a nurse, and she did OBGYN. And her doctor gave 2 to 3 days prescription for opioids after surgery. And if you needed more than that, the doctor had to see him again to make sure there wasn't a problem. That to me is good practice. But to live in Vegas and just have people from Video King filling out prescriptions and you signing them, that's insane. And he was hammered for it. But there should be a system, and we'll check on that. So thanks for that suggestion.
Other questions? Any final comments from any of the panelists? Travis, come on, buddy.
I'm sorry, I was talking too much, but I was very called to add something to that. I think you're absolutely right to be concerned about the anomalies. The only thing that I ask, that I beg of anybody, is not to let your concern for the anomalies overshadow the fact that you can absolutely swing the pendulum too far. And so I love the fact that the first thing the congressman said is that could be a pain clinic, right? Which is, it could be an oncologist, right? There are lots of reasons to prescribe more. The only way you would see across the board reductions is if every patient who was on long-term opioid therapy, who are sometimes on hundreds of morphine milligram equivalents, was immediately tapered. And that's really problematic, right? So one thing that happens, right, when this person got shut down, what happened to all those patients? Because I'll tell you what, if they actually have an addiction is defined by compulsions, cravings, and acting in the face of adverse consequences. Heroin works just as well as oxycodone, right? So it doesn't do us any good to just shut down a clinic and not do anything else, because we've just driven a population of people to heroin, right? So if you're gonna shut down a clinic, there has to be something else going on there, which is getting people help, getting patients help. And then there's a role for the DEA for sure. But another thing that happens is when the DEA sends letters that says, I'm watching you, which is something that happens, right? We've noticed you're a high prescriber. You're in the top quintile or something. That's followed by an immediate reduction in that prescriber's prescribing, which might be good if they were reckless prescribers, or it could be really bad because they were doing the responsible thing, taking on legacy and orphaned patients whose doctors had abandoned them. And now they're like, I'm sorry, I'm not risking my license for you, so I'm going to forcibly deprescribe you. So all that was like a really, I should have just stayed out of it, but I couldn't help myself. That's just a long-winded way to say nuance, which is hard in policy, right? It's really hard in policy, but we have to do it because slamming the pendulum either direction is a failure.
I'm Irish, so I always got to get the last word, so I'm sorry. But I remember the comment I told you earlier. This was 2 years ago. At the height of the opioid epidemic raging, my friend's wife comes out of the hospital in Washington, D.C., and a person in that hospital gave her a 30-day supply of OxyContin. She didn't want it. They made her take it. How do you stop that? And shouldn't that be something we can at least nuance, right? Yeah. Something like that. So you're right, and you're right. And I'm a politician, so I agree with both sides. So. I do want to thank Upstate because it's important to not just act on these things, to talk about, have these discussions, because I certainly have learned a lot in my perspective that I can take back. If you notice, I asked for his card because I want to look into some possible legislation and some things that he discussed as well. So, and all of you. So, if you have things, please let me know. Okay.
I've written them all down, Congressman.
You're not shy, and that's good.
I'll be sending Aaron an email
good.
shortly.
Yes.
Any other comments from anyone? Amy, Tim, Ross? Thank you very much to our panel. Appreciate all of your perspectives, and thank you very much to the audience for I think everyone stayed almost for the whole thing. So I think this has been a really informative day. I've certainly learned a ton. I've learned that it is complex, that it is very nuanced. We've generated probably more questions than we've answered, but I guess what I would ask the group here is to carry all of these questions and carry all these conversations with you, because you all, I see a lot of scientists and medical professionals out there, and you engage in lots of circles, and so please carry the conversation with you. And once again, thank you, Tina. None of this would have been possible without you, so thank you very much. Okay, have a great day, everyone. Thank you.